kick off now. That's okay. So I'm going to introduce Scott Cawley, who's the National Diabetic Foot Lead for Wales, and David Hughes, who's clinical lead at Swansea Bay Health Board, podiatry, orthotics, MSK. I'll hand over to you both.
Thank you very much. Prynhawn da, pawb, good afternoon all, and thank you for taking the next hour out of your very busy days to allow us to share some of the lessons we've learnt whilst embedding activation within podiatry and orthotics model of care across Wales, and our most recent use of the patient activation measure, or PAM, within the management of foot disease, specifically in relation to diabetes. Now, it's been left for me to share the presentation, so apologies in advance if this doesn't work. Is that sharing now?
Yeah.
Great, lovely. I'm David Hughes, clinical lead and assistant head of service in Swansea Bay University Health Board, and we serve a population of around 550,000 people. As a podiatrist, I'm constantly reminded of the growing incidence of preventable crisis, which threatens life and limb particularly, and the enormous human impact that this has. As an NHS manager, I'm continually reminded of the unsustainable, unprecedented health burden preventable crisis imposes. And since becoming a podiatrist, I also trained as a lawyer, and I'm always concerned around our assurance of good governance and how models of care must change in order for us to meet our duty of care for our patients and future generations. And as clinical lead, I'm constantly reminded of the Welsh Government prudent principles, which sit at the foundation of value-based healthcare, and how we must optimise the resource we have in our patients by working with them as equal partners to achieve outcomes that matter to them. So I'll now pass you on to Scott, my partner in crime, and he can introduce himself and some of the drivers for the work that we've started.
Thanks very much, David. As you can see, yes, Scott Cawley. I work for Cardiff Vale University Health Board. I'm strategic lead podiatrist and have been for many years. I've actually worked for the NHS for 42 years. I know, David, I don't look that old, but you know, I'll leave it up to you.
You're doing all right.
Doing all right. So I've worked within a diabetic foot most probably for about 25 to 30 of those years. I'm also the National Diabetic Foot Co-ordinator for Wales. Unfortunately, I've been working at the wrong end of the diabetic foot disease, where people end up having amputations, and we'll see later on the mortality rates that we have with that. And it's given me an insight into, I do not believe that when they were children that their concept of later on in life would be having to lose a leg. And unfortunately, 2 years ago, having worked for so long within the diabetic foot, I'm afraid I had a burnout, and I had to stop doing clinical work from now on. And I think the reason I'm here today and what has been driving me for the last 4 years is for better outcomes for patients, but also better outcomes for the clinicians as well. So I think we'll just get on with it now. I'm just going to put into context why we're talking about this. We know diabetes is a chronic condition, and it's one of those conditions, unfortunately, whereby self-management is so important, which will affect your outcomes. And unfortunately, they also need to be very participating in their care as well. Otherwise, we can see the consequences, the complications. We know that patients with diabetes can go blind, they can have kidney problems. We know they're more prone to heart attacks and strokes. And of course, the worst one, and hence why we're involved, is because of the amputations. And you see some of this data here. Diabetes is the most common cause of non-traumatic amputations with diabetic foot ulcers, preceding more than 80% of amputations in patients with diabetes. So if we can prevent the ulcers, then we can prevent 80% of the amputations. We also know 15% of the diabetic population in their lifetime will have a foot ulcer. And we also know that from the NADIA data that the diabetic foot disease is the most common cause of diabetes-related hospital admissions. Also, we know from our DIVA data, which we are now getting in Wales, is that there's a longer length of stay for these types of patients as well. But that's not taking into account the fact that foot ulcers and amputations impact hugely on morbidity, mortality and quality of life for people with diabetes. And to put this into context, mortality rates after diabetic foot ulceration and amputation are high, with up to 70% of people dying within 5 years of having an amputation, and around 50% dying within 5 years of development of diabetic foot ulcer. That's not taking into account the poor quality of life they've had before that as well. And we already know that 80% of the money spent on diabetes is spent on complications, but foot ulcers and amputations actually cost £1 in every £150 spent in the NHS. So what are we doing about it? What are our drivers? So obviously we got NICE, which is the Diabetic Foot Problems Prevention and Management, and that's just been reviewed again, 2022, which we made some comments on. And I'd have to say not much has changed in the last 15 to 20 years, which to me as a clinician, which I like to think I've been a bit of an expert, to carry on doing the same to get the same results doesn't seem quite right. And also we have the put and feet first pathway, which is supposed to direct care, and that's really come from that document. Then in 2016, we had the diabetes delivery plan, and that was the following on from the NSF. Which is a welcome, to be honest with you. At least we had 12 recommendations specifically around the feet. And one of the recommendations was that we would embed the principles of put and feet first pathway, because we knew it wasn't right. And to us, this is one of the biggest strategic drivers, is prudent healthcare, and particularly on that co-production with our patients. But to almost affirm what we were doing, it's lovely to see this document come out last year. It's called the National Clinical Framework. And within that document, it said some of the things that we've actually tried to do. And in that document, it says prudent and value-based healthcare. And it says there is a body of research showing that overtreatment and overdiagnosis produces real harm to patients. It is important that our focus on pathways does not drive patients into interventions that are not only in their interest, or unlikely to deliver the outcomes they want. And I think this is where we focused on the put and feet first pathway, and we'll come back to that later. In future, we need to foster more opportunities to understand what matters to the patients and to regularly check that patients' wishes have not changed. It is also important that this co-production of care is whole pathway and not confined to very specialist parts of the pathway. So we want a whole system approach to this. And I think this is the message for us all. It is that don't wait to be told. This framework is your permission to act. So what have we done then? So I'm just going to follow up with two last slides now, is that, so in 2016, the Diabetes Implementation Group came with some money, and hence that's where my post came from. And for 1 day a week, I am now the National Diabetic Foot Co-ordinator. First thing was that we set up a diabetic foot network. So we had people from all the 7 health boards, and all these people are influential. They are change agents because they sit on their own individual diabetes development and planning groups. You can see we're all wearing our smart t-shirts. That's to promote World Diabetes Day, which is actually on the 14th of November. So on the back of that, we then were able to secure some money from the then WEDS, which is now the HEIW. At that particular time, a few of you might remember they brought in care aims training. And this was being delivered by Kate Malcolmas, who's a consultant in ethical practice. And we had training as a network. They did make facilities just for each health board to have one program, but I was able to persuade them to take it on a national scale. And we took to that scale, we took to that program the put and feet first pathway, and it became quite clear to us that what we were trying to achieve was not right. So I just want to look at the inputs we had and then the impacts. Obviously, we had prudent healthcare. We had pathways already in place in Wales. But the important thing is we talked to groups. We talked to the Welsh Endocrinologist Diabetes Society, National Service Framework for Diabetes, the All Wales Heads of Podiatry and Orthotics. We also talked to the NICE facilitator for Wales as well, to make sure that what we were doing, trying to move away, didn't contradict exactly what we can try to achieve. But the most important, we talked to the All Wales Diabetes Patient Reference Group, and I think they've been influential in what we've been trying to achieve. So if we get it right, we hopefully will have a physical, active and healthier population, improve the patient confidence and resilience to self-care, improve quality of life, reduce dependency on health and social care, positive impact on economy and society, and this is very much down my street, improve well-being for the entire healthcare community of practice. So that's very good. So we took away the concept of we wanted to change the pathway, and within that pathway we wanted to use patients more. So I'm going to hand you over to David. So why did we look at PAMS?
So thanks, Scott. I think it's essential to remind ourselves of the current Welsh context and Welsh Government's vision for a more prudent future in Wales. By doing so, I hope that by the end of this session, you will see how all that we have done and continue to try to do by implementing activation-based models of care is inextricably linked to each of the 4 prudent principles and each of the 5 transformational ingredients for health and care in Wales. At the heart of activation is co-production with our patients, and we offer the following definition just in order for us to agree a common language. Working together as equal, as active collaborative partners, building on people's strengths and supporting them to achieve the goals that are important to them in the full context of their lives. And it doesn't take much thought to see how this is a fundamental component of value-based healthcare moving forward. It's therefore useful for us to reflect on the patient's perspective in all of this and how it feels being subject to historical, possibly paternalistic models of care when living with chronic conditions. This infographic by a patient demonstrates a year in his life, the green wave, the wavy line representing the ups and downs he experiences during the 8,760 hours he lives alone with his chronic condition. The red lines illustrate predetermined episodic consultations with his healthcare professional. These are fixed moments in time in line with historic guidelines which focus on the pathology and not the individual. You will see how these red lines are meant to represent safe, reassuring, possibly paternalistic care, but how effective are they? You will see that none occurred when the patient needed us most, and one of the 3 actually occurred when he felt he needed us the least. Paternalism breeds passivity, fosters dependency, and results in waste, harm, and variation. It may feel falsely reassuring to predict the need for follow-up, but it is in fact a hazard to health. One of our most worrying situations as podiatrists in particular is the increasing incidence of preventable crises. This graph here shows the high incidence of lower limb amputations across Wales, and it was from this graph that my own personal journey first started, as my own health board is represented there as the highest incidence of amputation of all the 7 health boards. The financial costs are unsustainable and the human costs even greater. Why then do we continue to be surprised that we continue to get the same output from the same inputs? In Wales, over half of the budget is spent on health and social care, despite 80 to 90% of health being made outside of the healthcare system. We know the statistics and incidence of poor health behaviours and lifestyles in our population, and we also know the impact these will eventually have on health and risk of crisis. So why then do we continue to focus on the silo pathology and not the individual as a whole? This led us to undertake a multidisciplinary root cause analysis in our health board of each of the non-traumatic amputations undertaken by our health board during the year 2015 to determine the contributory factors and any missed opportunities to prevent. This very, very busy slide shows how complex the contributory factors are to crises that lead to lower limb amputation, most of which are the clinical indicators associated with diabetes, renal and vascular diseases. However, the 3 primary contributory factors of our preventable amputations were not clinical, but were instead patient factors, indicative of their level of engagement and activation in their own health. Of the amputations reviewed, 80%, in line with the literature, were considered preventable. Of the 80% considered preventable, nearly half were due to patient factors alone and not clinical care or service delivery problems. It was therefore essential that we changed our focus from paternalistic models of care that were not serving our population. It was essential that we looked at how we might work more effectively with our patients to support them to address the patient factors which threaten their future life and limb, and moreover, learn from the individual to ascertain what barriers applied specifically to them as individuals. We started by embedding brief lifestyle interventions in all that we did using the Making Every Contact Count methodology. We also introduced our measures for Making Every Contact Count activities and recording positive behavioural changes as they happened. We realised that 30-second to 2-minute brief interventions would not suffice if we were to truly coach the patient and carer to engage as equal partners within their care. We therefore extended co-production based on the Health Foundation co-creating health model and self-management support training for the entire workforce. We embraced the concept of self-reported importance and confidence scaling as an indicator, as a rude and crude indicator of individual need, their progress, and implemented pre-consultation questionnaires. Finally, we get to where we are today, having acquired the resource to fund the Patient Activation Measure, or PAM licence, for 20,000 patients living with diabetes in Wales. The PAM now provides us with a validated measure of a patient, carer, or patient's or parents' activation or problem-solving ability. And this validated measure opens up now essential opportunities for us to identify the individual patient factors and needs so that truly patient-centred bespoke management plans can be agreed to achieve goals that matter to the individual. Activation is changeable and describes the knowledge, skills, confidence and importance which relate to the individual's ability to self-determine and engage in the positive behaviours. And the work started by Hibbard and Gilbert 2014, and their model for patient activation continues to demonstrate that high activation levels are commensurate with positive behaviours, improved patient satisfaction and improved outcomes, preventative, restorative, supportive and palliative. Conversely, low activation continues to show high levels of dependency, reluctance to seek help, continued failings, increased fear or apathy, and poorer outcomes. From Hibbard's work, we can see how a better understanding of patients' importance and confidence can enable us to change what we do and when we do it, so that it occurs when the patient's problem-solving abilities are sufficient. For example, I was always taught to ensure a patient is provided with as much information and education around their diagnosis as soon after diagnosis as possible. And I'm sure many here today will have similar experiences of doing this as the right and necessary thing to do. However, how many patients actually respond well to this information? How many have the problem-solving capabilities or activation to use this information well? Hibbard argues that education and information should not be commenced until a patient's in action mode with moderate to high importance and confidence. Conversely, to do so earlier has the potential to set the patient back even further, lose confidence in their abilities and become even more ambivalent in their care. Again, without considering activation, education and information giving as a one-size-fits-all package at the earliest opportunity may feel falsely reassuring, but can be a hazard to health. Two examples here of many meta-analysis support the universal findings of the benefits of patient activation and its measurement. PAM increases predict improvements in behaviours across long-term conditions and across multiple studies. Improvements in patient activation were more likely to occur if the intervention, including an interdisciplinary team. Interventions that significantly improved patient activation levels tailored the intervention to participants' pre-intervention activation levels. Patient activation interventions produce significant effects on outcomes related to physiological, psychological, behavioural and health-related quality of life in the context of chronic disease. And finally, healthcare providers are advised to implement patient activation interventions that tailor support to the individual patient's level of patient activation and therefore strengthen the patient's role in managing their healthcare to improve their outcomes. So now let's apply all of this now to ourselves so that we can develop a clear understanding and possibly a brighter empathy with our patients. So let's consider what we do, when we do it, and question, do we need to change for the better? So firstly, think, do you do anything on a regular basis that you know is bad for your health? That you know is bad for your health? Do you know what and how to stop doing that thing that you know is bad for your health? If you have the knowledge and skill, then why are you still doing the thing that is bad for your health? How important is it for you to stop doing what is bad for your health? On a simple scale of 0 to 10, with 10 being fully important and 0 being not important at all. How confident are you to stop doing what is bad for your health? On a simple scale of 0 to 10, with 10 being fully confident and 0 being totally confident. By just asking those two simple questions in relation to importance and confidence, take us closer to scaling true activation. By not focusing simply on knowledge and skill, but by thinking about the patient factors that actually enable the patient to put knowledge and skill into practice in the context of their lives. So hopefully by doing this and having this reflection ourselves, we now have a bit of a better idea of our own activation and what may support us towards improved health. Having reflected on our own activation and barriers to change, we may now have a clearer perspective on what actually may work better with our patients. How heavily are we focused on raising a patient's knowledge and skill in our current models of care? When do we provide our education and information and advice to our patients? Is it at the beginning without any knowledge or intelligence about that patient's problem-solving capability? How heavily are we focused on patients' importance and confidence to act as equal partners in their care, and the barriers that possibly, with support and good coaching, may actually be overcome? What might be the consequences of providing education, information and advice to our patients who may not be sufficiently activated at the time we give it? When importance is low, what can we do to support the patient? When confidence is low, what can we do to support the patient? Now, this is a very busy slide, not just because of the number of words in it, but also because of what it represents and how we become so busy and overwhelmed by duty that we can sometimes become unsafely shackled to guidelines, including NICE. Mark Baker, Director for the Centre of NICE Guidelines, provides this essential advice and reinforces the message that the right thing to do is determined in each individual case, in line with individual needs in the context of the individual's life. NICE recognises that the healthcare professional is best placed to make this call. The healthcare professionals are the people who see, treat and talk to their patients about what they want and need. I would also offer that an activation-based approach as part of true co-production is a duty and not a choice. In the words of Angela Coulter, how can we truly meet our duty of care without having full regard to this learning? How can we truly say that we are working prudently to minimise waste, harm and variation? How can we consider a more sustainable and healthy future without regard to this learning? Doing things to people instead of with them can be profoundly disempowering. It encourages patients to believe that we as professionals have all the answers and that they themselves lack the relevant knowledge and skills, and hence have no legitimate role to play in decisions about their healthcare. Paternalism breeds dependency, encourages passivity, and undermines people's capacity to look after themselves. This may appear benign, comfortable, and reassuring, but it is a hazard to health. And with all of us registered healthcare professionals, we all have standards set by our regulators, and each of the regulators focus on the standards for self-management support. Hence, the HCPC dictates you must encourage and help service users, where appropriate, to maintain their own health and well-being and support them so that they can make informed decisions. If you are a nurse, medic, or registrant with any other regulator, you will see much the same language used in your own standards. Once we had embedded the co-creating health model and importance and confidence scaling with our patients, we implemented a pre-consultation questionnaire. We revised our national podiatry taxonomy of need to ensure need is now informed for the first time ever by the individual's problem-solving capability and the individual's coaching needs. And finally, we developed an addendum to the nationally agreed paternalistic diabetic foot guidelines, putting feet first, in order to embed activation as a distinct hazard in itself, to inform more meaningful patient-centred management planning. Pre-consultation questionnaires enable us to determine what matters to the patient at the earliest opportunity. Waiting time should be seen as wasted time, and giving the patients the option to reflect before consultation promotes a better understanding of the context of a patient's life. Exploring the patient's perspective, very, very powerful to us. Identifying the patient's agenda and what matters to them, helping us from the first moment we meet them, build a strong relationship of trust and rapport. It enables us at the earliest opportunity to gather excellent quality information, learning about the patient's health literacy, how they filled the form or not, scaling their activation to self-manage, prioritising the agenda, exploring any ambivalence, overcoming any barriers, building on their successes and building on their confidence, raising their confidence for the future. It allows us to make efficient use of the time. Here are just a few responses by staff in relation to the power of the pre-consultation questionnaire to support effective co-production and determinations of need and risk. They are all positive because it is a positive experience to use the pre-consultation questionnaire. It's completed in the patient's own time, and it gives us the rude and crude intelligence to be able to move forward and consider the patient's problem-solving ability. However, we need to remind ourselves of the work of Hibbard, and knowing that a patient's activation level enables us to tailor our interventions now to those which help and not hinder the patient. Lower activated patients need frequent, short interactions with coaching for baby step goal attainment to build confidence. Higher activated patients require less intensive resources, can be more safely self-directed. All patients as part of the licence have a score out of 100 to a level which opens bespoke coaching resources that match their unique level. Here is our revised podiatry taxonomy of need, which gives full consideration now to the potential hazards of low activation. It also ensures resource allocated where it is needed most and identifies where there are high activation levels and opportunities for more self-directed self-management. In our area of podiatry, here are the historic guidelines that we have historically been shackled to. They are, as many pathways and guidelines continue to be, extremely paternalistic. They focus on imbalanced assessments of clinical hazards and automatically translate those and the presence of such hazards to determinations of risk. By ignoring the patient's problem-solving capability or activation, those guidelines basically state the patient has nothing to offer. In other words, these guidelines ignore the patient's own capabilities and potential opportunities to avoid hazards and prevent crisis. We must acknowledge that those patients who can already see the banana skin in the room and trust them to avoid it. We must acknowledge and identify those patients who can't or won't see the banana skin in the room so that we can work with them to see and avoid them. If we do not, we cannot expect that hazard not to become a realised risk and a big slip to occur. One-size-fits-all approaches fostered by guidelines and pathways that ignore patients' activation lead to wasted resource allocation, breed dependency, and encourage the passivity that we've talked about. They also label the patient with a static risk status, with no incentive to change their behaviours that in reality can actually reduce their risk. I then set up to embed activation as a PAMS score and importance and confidence scores within our addendum to the Putting Feet First national guidelines. And this now ensures that actions are not just based on the presence or history of clinical hazards, such as previous ulceration, but also now on the patient's activation to avoid those hazards and prevent crisis. I'm glad to say and proud to say that this is now an addendum to the guidelines which has been adopted professionally by podiatry and orthotics across Wales, and this activation-based model of care is now the bedrock of how we are taking this forward. So I'll now pass you on to Scott to talk a little bit about our data so far.
Thanks, David. That's a great overview. So I'm just going to take you now to what have we done then. David talked about 20,000 licenses. Part of the diabetes implementation group was money was made available for putting bids that we would then try to change practice. And we put in 2 bids to use the PAMS license, which comes from Insignia. And it was for 10,000 licenses for the first year and then 10,000 licenses for the second year. It's unfortunate that during that particular time, of course, COVID hit us, and we've been very lucky to have it for the second year, and we've been able to move the licenses on into that second year. So David did show you the 13 questionnaire, so that's very good, but how does it translate into identifying what the patient's activation level is? The first thing is that this PAM can be administered in either face-to-face in the clinic, it can be via the phone, tablet or email before the patient's actually arrived to your clinic. It's in 35 languages, unfortunately it's not in Welsh. And it can actually be for the individual themselves, it can be for a carer, or it can be for a parent. And on the left hand side, you can see this is the sign-in page. It's a web-based platform, and you've given a unique username and password. And I'm just going to take you now to what we see. Okay, so within that platform, we have some training modules for the staff. So you have an understanding, what does an activation level 1 patient, what's an activation 2, 3 and 4, and what does it mean in the true context of that patient participating in their care. And if we could just have the next slide, David, and these are these levels. Here's level 1. The patient is normally disengaged and overwhelmed. Individuals are passive and lack confidence. Knowledge is low. Goal orientation is weak and the adherence is poor. And their perspective is, my doctor is in charge of my health. How many times have I seen that where the person just comes in and puts their foot in front of me as if it's my foot, not their foot. Level 2, becoming aware but still struggling. Individuals have some knowledge but large gaps remain. They believe health is largely out of their control but can set simple goals. Their perspective, I could be doing more. And then level 3, taking action. Individuals have the key facts and are building self-management skills. They strive for best practice behaviours and are goal orientated. Their perspective, I'm part of my healthcare team. And then level 4, maintaining behaviours and pushing further. Individuals have adopted new behaviours but may struggle in times of stress or change. And maintaining a healthy lifestyle is a key focus. Their perspective, I'm my own advocate. Now within the web-based platform, we also have coaching for activation. So we have some examples. Here you see PAM1, level 1. And this will give you some indications which the clinicians can use to help support the coaching of their patient. So I'm just going to take you on to what the dashboard looks like now. So we started this most probably at the beginning of the year. In Cardiff and Vale, we were the first ones to be able to get it through. And I'll explain why. Then come Taff and now Swansea, and I know AB are coming on board fairly soon. And we've put 843 individuals across those 3 health boards now. And that's telling us what the percentage is of level 1 up to level 4. We've got 99 active coaches, and it was also tell you the number of PAM surveys past the due date. So we've got still quite a bit of work to hear. We've also got outlier percentage. These are patients who have scored themselves, but it's showing up some anomalies on that form, and they're used as percentage outliers. We also have a readmission rate of 5% currently, and that will show you the change in score when they've been repammed. So I'm just going to take you quickly now just to these 3 health boards I talked about. Here's Cardiff and Vale. We've used it now on 683 patients, and we know the general population, 25 to 40% of the general population have low activation scores. And you can see patients coming into the podiatry in Cardiff and Vale would actually equate to about that figure. If we look at our neighbouring health board, unfortunately, they've got 154 patients, and now they've looked like it's about 61, 62% are in the low activation. And if we go back to what we understand, patients who are low activated have poor outcomes and use up an awful lot more resources. It tells you potentially what the capacity is going to be required to deal with these patients going forward. And then we just look at Swansea Bay, who've only just come on board, to be fair, and they're hovering around just over the 45% mark as well. We also have the ability within the web-based platform to be able to split it down into certain groups, and we've used these groups: active as wounds, MSK, generalist, BAME groups, podopeds, nail surgery and orthotics. These are our main groups that we're likely to have provision for in podiatry services. You look at the MSK, they got a PAM mean score of 69.8. You can see a lot of them have fallen into high category for activation, most probably because pain is a great predeterminant of actually doing something about it. Generalist, you can see it's about that 40% in the generalist. And then we come to active wounds. Now you might be surprised about that actually you'd expect the activation in those patients to be lower, but actually it might be the incidence of the ulceration itself has activated the patient. But we also know that roughly 70% of the patients who have active ulcerations are males, and sometimes that when they are filling the form, we do sometimes wonder, is it accurately being filled in? And I think some of those could be the outliers, and we can drill down to that as well. And this is a good slide. This just goes to show what baseline PAM scores were compared to the re-PAM. So the ones on the left side are the baseline PAMs, and the ones on the right hand side are the follow-up PAMs. And you can see it's gone down from level 1 and down to level 2. It's gone up in level 3 and level 4. This is really encouraging. It's also very encouraging for the clinician when they re-PAM the person. They can see they've gone from a level 1 to a level 3. It reiterates what we're trying to achieve. So let's just look at some of the benefits that we're hoping this will achieve going forward. Improved wound healing and reulceration rates. We already know from the National Diabetic Foot Audit that those patients that self-refer have better outcomes and less severe ulcers. So it's about those patients being activated to be able to participate in their care. Obviously, it would reduce new and follow-up demand, so you free up capacity so patients are able to get into your clinics based on need. Reduced waste and reductions in DNAs and CNAs. Increased clinic capacity, primary, community and secondary care settings. This has always been a concern about patients. They always felt that if they weren't part of the service, they'd have difficulty getting back in because you've got 2-year waiting lists. Increased crisis prevention. This is an important one. Hospital admission avoidance, when we talked earlier about length of stay, the costs. We also now governed about putting people on pathways, and it's nice to know that when we put someone on a PIFU, which is a patient-initiated follow-up, that they are activated to actually come back to see us at a times of crisis. And obviously timely access as seen on symptoms. Improved patient satisfaction, hopefully you see a reduction in complaints and incidents and claims. And population health, healthier behaviours, reduced BMI, improved diet and exercise, NERS, increased smoking cessation, and of course, we want to see staff well-being. What were the challenges? If we just have a look at the challenges to implementing this, we've all been trained in a medical model, so it's very difficult to start with training the podiatrists into a new way of thinking. We secured some money, and David was able to go around the whole of Wales discussing what PAMS was about. It's also paternalistic. It's reassuring, David's already talked about that, to be seeing these patients on a frequent basis, but it can be very harmful. Resource, we had again some money from the implementation group to be able to buy these licenses. The reason that Cardiff and Vale were one of the first ones to get on board with this was because the information governance around the DPAs to get it signed off, because obviously we're working with an international company. And also language matters. Patients don't like the word activation. Our All Wales Patients Reference Group, they did say they don't like it. They like the concept, what it means, but they don't like that term. And of course, Welsh translation, for it to be embedded, we have to have it translated because obviously part of the Welsh Language Act. And of course, COVID crisis hit us when we had the first license. But I think this is more as an enabler than anything else, because that did tell us something about actually why we're trying to achieve what we do. So actually at times of crisis, patients were able to look after themselves until they really needed us. The next steps, we need to increase the ascertainment rates, bring on the other health boards and podiatry teams. We also want to re-PAM the coaches to see if their activation levels to participate in is increased. We also need to seek long-term funding so it become embedded into general practice. And we need to initiate it into the undergraduate podiatry program so those clinicians come out with the right skills. And we also need promotion to other conditions and disciplines. And for it to sustain ability, it requires the models of self-care and behaviour to hold equal relevance and importance as medical care. And I think that is what we need. And that's not what we're seeing in NICE at the moment. So just to finish off, the only way we can do it is we can do it together as clinicians and patients. And I love this quote from Gillian Clark. She says, "We need passion and belief today to help save our NHS. It is everybody's favourite organisation. We all believe in it and it must not die. And it's not just the health experts that will save it. It's me, my children, my grandchildren, my neighbours, my community, my friends. And I think that sums up exactly what we're trying to achieve. I'm not saying it's going to be easy. David and I, we've been working on this now for 3 to 4 years. Okay, COVID came in between. We've had many meetings in MacArthur Glen to make sure that what we're trying to achieve is correct. But we truly do believe this is the way forward to sustain our NHS going forward. So we'll just leave it there now, and we will ask if we've got any questions.
So thanks both for a really, really interesting presentation. If I start off, there's a couple of comments in the chat that I can share. So just scroll down. So Claire Madsen, who's unfortunately dropped off the call now, but she says, what licenses are available in Wales to use this outcome measure?
Okay, that's an easy one. I believe that we are the only purchasers currently in Wales of the licence. We've purchased it for 10,000 patients for 2 years. So that will be 20,000 patients in all. It's like anything else, it's cheaper if it's done en masse. So actually we've done it the most expensive way, but because we've done it, you know, small scale. I really think that it's sessions like this that gets the language and the discussion and the thirst for activation to take that forward, and hopefully we can find a way, as there is in England, where Public Health England provide the licence to all.
Thank you. And then Natalie Robertson from Cardiff and Vale, she says, how can use of PAM be streamlined so that service users aren't continually completing this in each service or profession that they attend?
Oh, that's another easy one. Do you mind if I?
Yeah, I think what we realise is that actually the PAM score stays with the patient. And actually, we have our IT systems who are sufficient enough for actually, if they've been PAMmed by podiatry, because this is not uniquely podiatry scores we're looking at here, is their behaviour, patient's behaviour. So if we have the PAM score, that it'd be quite easy to be shared across the IT systems. And I think that would make it very much easier. If you saw a patient coming in and you knew exactly what their PAM activation level was, then that would certainly help.
Much like a blood result.
Absolutely.
It should be done once and available to all. That's exactly the same with PAM. And the important thing to realise with PAM is the PAM score is carried with the patient. And that's not just in health, that is also in their interactions with third sector. So it's outside of the health service as well that PAM score would be taken.
Yeah, I think we also, the PAM's licenses for the individual patients, so you can re-PAM them as many times. It doesn't mean you have to keep having to use up another license. So it's actually 20,000 patients and you can re-PAM them as many times as you want.
Thank you. Natalie also says, have you employed peers as part of this work? And if so, what roles have they undertaken and what's been the impact?
Peers?
Peers, as in
peers.
Your peers. Yeah, sorry.
Okay, so yes.
As in peer support workers. So actually someone who has a lived experience of potentially having an amputee or a person living with diabetes with sort of poor foot health or anything like that, that have sort of been through some of the pathways that you're talking about, and whether they have been whether they're what part are they as part of this project, or have you employed them as a substantive role in looking at your activation levels and those sorts of things? Sorry.
Really good question. Not in a substantive role as part of the project. However, that's not to dampen down the impact they've already had and continue to have in the project design. The root cause analysis was all about patients, and it wasn't a paper-based root cause analysis, so it did involve the interviewing of all patients that lived that experience that led to the amputation. Sadly, we couldn't with all of them because, as Scott pointed out, many of them post-amputation had died. But we also have, at every step of the way, engaged with the patient reference group who continue to live the experience of living with diabetes as a chronic condition, and being able to provide us so that we can inject their responses and their opinions and advice in every step of the project. It would be lovely if we could utilise the patient experts, for example, to be able to inspire and share the lived experience a lot more. And I'm sure when we can demonstrate quite purely that a patient's activation has happened and that has resulted in improved outcomes for them, etc., we will along the way be picking those patients and begging them to share their story, to be able to activate and inspire others around them.
Natalie, do you have any more to say? You did ask.
No, thank you. That was lovely. That was really brilliant. Thank you.
Natalie's also asked if you're able to share the pre-questionnaire.
Yes.
That's fine.
We share everything.
Lovely. Sarah and Clements. Sarah, do you want to come and ask your question? We've got a few more minutes left yet. I think you're still here.
Yeah, I'm still here. Thank you. That was so inspiring. It's such a good way of involving patients, and it goes through. We're doing lots of work in Cardiff about motivational interviewing, and it's all about that. It really fits well, doesn't it? And looking at outcomes that really matter to people and using our resources really well. I was just really asking about sort of funding and the costs of this. Obviously, you're able to do it on All Wales. Do you know if it is going to come to Cardiff and therapies? Are we looking to move towards that, or costs, that kind of thing?
We have some experience already that people want to participate. We know the reablement team are looking at this as well. So we know that people have shown a real interest. We have to show the concept first, and this is why we've taken it as part of the diabetes implementation group. The whole idea of the diabetes implementation group is that they give you a small pot of money, and then obviously you hope your own health board is going to pick it up, or someone's going to want to pick it up. But we are getting a lot of drive at the moment. People are asking about it and they're looking to want to use it. So this is why we're also doing these webinars now, to actually try to promote the work, what we've done, because we're very aware that the license we've currently got is going to end at August 2023. So we're really trying to make a drive on this. This is not new to Welsh Government. They did an appraisal in 2015. I don't think we got anyone from Welsh Government on the talk at the moment, but it would be nice to be able
Ruth
to.
was here. Ruth Crowder.
Thank you, Ruth. There we are. So it'd be really nice, and I think this is what we wanted to do. We wanted to show the concept and the success that we can already see with our patients, and we're hoping that, you know, Ruth is a great advocate to what we're trying to achieve, that we can try to take this forward.
And we're talking pence per patient, and again, when we talk about more licenses, we're talking about even less pence per patient, and that carries that patient for a 12-month period through all healthcare and all third sector involvement. That rich language to be able to dictate what we do that matters to that individual. So it's about going from here, and if you are converted or you are beginning to be converted, then it's spreading the word of what could potentially be achieved for those small pence. And
I was thinking I was thinking, because I'm a Macmillan profession, so whether somebody like Macmillan would be interested looking at pathway developments for our patients as a project. But that would be great. Perhaps I'll pick both your brains about that at another time then.
Please do. I just wonder if there's any funding streams through Valley Based, because there was money being made available, wasn't there? So whether there's any money still to be had.
I think
did you say Valley Based
on a national level, though? Yeah.
Okay.
I think money was made available for a local level and at a national level as well. So whether that the UHB you're in has got any money available still. I don't know.
It's Cardiff, I don't know. I'll ask. But it could be an all Wales project, because obviously that, you know, we have Macmillan, but that's brilliant. Thank you so much. I'm very inspired.
Thank you. What a lovely word.
So thank you, Sarah. So we've got another question from Enzo, who's from Cwmtaf. So Enzo, do you want to jump in as well? So we're doing quite well. We've got a couple more minutes.
Yeah, that's great. Thank you. I'm trying to put my camera on, but there we are. If I come up, great. Yeah, no, I was interested in the generalist data. Some of the data is really fascinating, and you know, since I've asked that question, listening to a lot of the thoughts from people on the panel, that the data can actually cross over. It's not really about it being in foot ulcers or here, there, and everywhere. I work in weight management, and it would be wonderful for us to kind of have it as an outcome measure, but not necessarily have to worry, or not that's the right word, but you know, have to put it into a clinical procedure and think, actually, this could be carried out elsewhere. If it isn't done, then you know, you take that measure if it's not done within a certain time. So this really suits an all Wales kind of project in my view, based on what you're saying. It would be absolutely fantastic, and we could do this on an all Wales weight management thing as well. It would be a wonderful thing. Absolutely. So yeah, very impressed, really like it, and I've kind of lost the question there because I'm gone into affirmation mode. So
that's lovely.
Thanks a lot.
Thank you. Thanks, Enzo. So does anybody else have any questions before we wrap up? No. So just to say thanks very much for joining, and thank you so much, David and Scott. It's been really, really interesting. Just to say, we do have another session, a repeat of this session on Thursday morning at 11 o'clock. If any of if you're thinking of any colleagues you want to tell about it, and they're very welcome to drop me an email, Debbie Harvey, and I can register them. If you would like copies of slides, if you've got any more questions for Scott and David, if you don't mind directing them all through me, I can collate everything after Thursday. So yeah, that's it really. So thank you very much, everybody.
Thank you very much, and on behalf of Tweedledum and Tweedledee, thank you for supporting us and hosting this, because it's just you've just all pointed out this needs us all to talk and keep talking for it to become a whole system change.
Lovely. Thank you all then. Have a lovely rest of the day.
Bye now.
Thank you. Bye bye.